Jungle. Audio Jungle. Audio Jungle.
Yes, Dr. Madhulika can start.
Yes, sir. Hello, ma'am. Hello, sir. Hello, everyone. I hope I am audible.
Yes.
Okay. So, good afternoon to all. I hope you all are having a great time. I'm Dr. Mathulika Banerjee, MDS from Rama Dental College, Kanpur. So, I'll be your today's moderator for the poster competition organized by Dental Reach, Making Sense of Dentistry, supported by Group Pharmaceuticals Limited. And yes, this is the leading number one dentistry publication which has gained its popularity among the dentists. So, for today's session, on behalf of Dental Reach, I welcome all our honored judges and enthusiastic participants as well. So, now let's welcome our first judge, that is Dr. Remy Ma'am. She is a gold medalist in BDS as well as in MDS from the Department of Prosthodontics and Oral Implantology. She is the first person from Gujarat to be appointed as editor-in-chief in the national magazine IDA Oral Health and has gained lots of achievements in her own field. And currently, ma'am is working in Government Dental College and Hospital Jamnagar. This is really fantabulous, ma'am.
Thank you so much, Madhulika.
It's my pleasure, ma'am. Would you like to speak something, ma'am?
I would first of all like to thank Dental Reach for thinking about this innovative idea of having a virtual poster presentation. Certainly, a lot of talent which we have across the country, most of the time they are not able to come either because the time is not comfortable or because they're not able to travel that time. Monetary
Hello?
factors also come.
Uh,
So we have got really great entries for Dental Reach. So I would like to congratulate Dental Reach for this program, and I would like to thank you. Thanks, Dental Reach, for finding me worthy to judge today's event. Thank you.
Thank you, ma'am, for the wonderful words. Now, I would heartily like to welcome Dr. Himanshu Eran, sir. He is the Director, Principal, Professor, and Head in the Department of Prosthodontics and Oral Implantology from Seema Dental College and Hospital, Rishikesh. He is also a visiting professor in AIMS from Rishikesh. Sir has achieved numerous academic and professional awards in his field. We are honored to have you over here, sir, and thank you so much for providing your valuable time to us and to this event. Has Himanshu sir joined?
So we are audible. Can you hear us? Okay, okay.
Am I
Hello,
audible?
sir. Yeah, yeah. Hi, sir.
Hello. Yeah. Good
Yes, sir.
Good
afternoon.
afternoon, sir.
Yeah. Hello. I congratulate Dental Reach for this wonderful show and to ignite this program, which will definitely create the interest among students for the awareness about the and being. I'm always there to promote prosthodontics, and I have been the president Indian Prosthodontic Society in 2015 and 16. So I again extend my heartfelt thanks to Dental Reach to promote my specialty, and I am honored to be one of the judge. I will try to give justice the duty given to me. Thank you.
Thank you so much, sir. We are honored too to have you over here. And now it's my great pleasure to welcome our dynamic judge, that is Dr. Nupu Shirao ma'am. She is the consultant prosthodontist in Chandigarh. Ma'am has done her MDS from VSPM Dental College, Nagpur, and is the editor in Dental Reach. Her dedication towards the field of dentistry is commendable. Thank you so much, ma'am, for joining us today.
Thank you, Dr. Madhurika, and hello, Dr. Himanshu, Dr. Rimi. It's very nice to share the judging panel with you both. And thank you, Dr. Roxon, Dr. Zainab, and Team Dental Reach for giving me an opportunity to judge this very interesting poster competition. And I look forward to the participants. Best wishes to all of you. Thank you.
Okay, so now before moving on to the poster presentations, let me remind everyone that each presenter will get 10 minutes, that is 5 minutes for presentation, 2 to 3 minutes for question answer session, and 2 minutes for any kind of technical issues. I think all the presenters have not joined yet.
The first presenters have joined. We can start with the first session.
Yes, Dr. Vishwas Bhatia sir, you can start with the presentation.
Good afternoon, respected sir, and all respected judges for taking our time for judging the wonderful event. Am I audible, ma'am? If anybody can please tell me.
Yes.
Hello, am I
you're
audible, ma'am?
Yes, you're audible.
Yes, you're audible to us.
Yeah, I would just request to kindly bear with me because I'm traveling today, but I wanted to do the presentation. So if any glitch or anything voice is missing, please let me know in between. Thank you so much. So the title for the presentation is I'm audible right now.
Yes, sir, you're audible.
The title for the presentation is Digital Function Finger a Prosthetic Bone. Now, when we come to advancements in technologies in India, we need to understand that as a prosthodontist or as a dentist, what I feel is the personal satisfaction I get when I try to use my knowledge and my experience. I've been practicing for pretty close to 17, 18 years now in basically trying to impart that knowledge into others, into fellow students. Along with that, also making use of our knowledge, especially for specially abled people, because we do regular treatments day to day. But for specially abled, we have been making finger processes, and I have been doing a lot of work in maxillofacial processes. But when we our aim is to ask them the problems which they are facing in this, like what are the problems. One is when we used to give the finger processes initially, and till date also we are giving processes which are made either of acrylic, and now we have also shifted to silicone. But the basic disadvantage of those processes is they are basically for function. They are basically not for function, because they are hard, they are rigid, there can be made no movement in them. So this is the way in which I tried to utilize the in technology, that is the 3D printing technology. It came to my mind that why not measure different parts separately, okay, taking the middle, top, and the bottom finger flanges, and then converting it into digital knowledge, using our digital knowledge in CAD/CAM.
Doctor, you're not audible.
Dr. Vishwas, there is
I think there is some technical glitch, sir.
Am I audible now?
Yes, you can continue.
Yes, sir.
now you are audible.
Am I audible, sir?
Yes, now you are audible.
Am I audible? The thing is that once we are able to fabricate that middle part, that is the knuckle part, we can always use 3D technology to fabricate different parts, as can be take the measurements of the width, the diameter, the length of the finger. Uh, Once the digital image is gained, am I audible, please? If anybody can tell me.
Yes, Dr.
Hello.
Vishwas, you're audible. Yes, Dr. Vishwas, you're audible.
Yeah. Once the digital data is transferred, as you can see, that is the most important part. That is figure number 4. You can see different parts fabricated through 3D technology. And what we need to do is we need to just join one part into another. Like we have seen, this idea came to my mind when I saw some tools, the toys which children buy these days for like DIY, using the DIY technology. Like, they have different parts, they join, they can make robots out of it, which are movable. So it just came to my mind that I can use 3D technology to make these different parts separately. And as you can see, there is a thread which is connected to a band. The band has to be worn by the patient. Once these parts are connected, once the 3D, after the measurements are done and the 3D parts are made, we connect them together. It's just a socket ball attachment. We connect all of them together, and there is a string which goes from that band. It crosses over the topmost flange of the where the artificial finger is connected to the natural finger. Then it goes downwards, connects to the tip of the processes. So what does is, when the patient wants to write, when the patient wants to move, he will take the part of the natural finger which is left. When he does the movement downwards, the thread is going to pull all the 3 parts of the finger in a curve, which will help him in not many things. Like, we have just put a pen. He can easily use a paintbrush. He can easily use it to operate a lift, and he can easily use it for so many purposes. So if you see the finger processes in the final figure, that is figure number 6, you will see, try to made it close. How? Because we have, after the fabrication, made a thin silicone sheet over it to give it a little natural appearance, so that the white parts are not visible. And then we have painted the knuckle part, and paint is easily paintable on the 3D printed parts. Paint part is done, then a silicone thin sheet is made, and like an elastic, it is rolled over all the 3 parts. And what you have in the final processes is a finger processes which is movable, which is functional, and it not only boosts the confidence of the patient, it really helps a lot, which our surveys have done which we have done.
Again, there is an issue with sound.
Dr. Vishwas is not audible to me.
Doctor, you're not audible. Time is up. Now over to you, judges. Sir Himanshu, sir, if you have any questions.
Yeah, Dr. Vishwas, can you hear me? Hello?
He's not here, sir.
You is not updated?
I think Dr. Vishwas has got disconnected.
We can start the other presentation. We will note down the questions and we can discuss if it is okay with the
Sure, sir.
organizer.
Yes, sir. We can
Sure.
go to the next one.
So our next presenter is Dr. Harsimran Kaur.
Yes, good afternoon, everyone.
Good afternoon, Dr. Harsimran.
Good afternoon. Can I start presenting my screen, please?
Yeah, sure.
You can start, Doc. We are showing
You
it for
can
you.
start with the presentation.
All right. Thank you so much to the organizing committee of Dental Reach uh, program and all the jury members here present today. And thank you for taking out time to hear this presentation of mine. So today I'll be discussing about something regarding cranioplasts. So whether we should go in for hybrid or manual cranioplast, let us unriddle this problem. So what exactly is a cranioplast? It is a cranial implant that is used mainly to cover a defect in the skull, and by doing so, we actually protect the underlying neurological structures, and we try to make the continuity of the region with the skull. And it also helps in improving the aesthetics. And there are some psychological depressions related to the patient when he's suffering from such kind of defects. So that also we can overcome with the help of these kind of prosthesis. So there are few challenges which are there when we are planning to fabricate a cranioplast. So the challenges can range from the aesthetic or functional outcomes to avoiding any kind of secondary infection which can happen after the surgery, and the strength of the material which we are going to use, it should be tough enough so that there is no fracture of the cranioplast in case of repeat injury, and at the same time it should be economical. So the foundation of prosthodontics is basically the good impression making. Generally it is said that first right step is the is the gold standard for all the prosthodontic outcomes. So first right step is impression making. Let us see how we can make impressions when we are talking the manual protocol, and when we are talking about the hybrid protocol. So in case of manual protocol, if we see it on the left side of our screen, I've discussed one patient here who was reported to us through the from the neurosurgery department with a big cranial defect on the left side, and it was after the road traffic accident which she had met with. And for that, the standard protocol of impression making, what we do in prosthodontics, was done with the help of the alginate material, and which was surrounded by the modeling wax, and then the analog was prepared and the wax up of cranioplast was done. This patient was comatose, so we had to take all the equipments with us to the ICU, and the try-in was also done there itself. And then the processing and finishing of the cranioplast was done in the lab, in the prosto lab, followed by the insertion of the cranioplast by the neurosurgeons in the OT. So this was one case. The other case, which is there on the right side, is showing a patient again referred to us from the neurosurgery department with a big defect on the right side, and this particular patient had right hemangioma, so which was actually removed by the neurosurgeons, and there was a lot of intracranial pressure which had got risen, and because to compensate for that, they had done the cranectomy. So this patient had come to us, and here we had actually opted for some hybrid kind of a technique in impression making, wherein the CT scan was utilized and the slice thickness of each image was 1 millimeter. And then this particular CBCT was sent to the lab, wherein the DICOM data was converted into .stl files, and these STL files were then converted into virtual models. And then virtual models, once approved by the prosthodontist, was actually printed, and you can see the realistic models also present here. And then the wax up and manipulations, everything was done on this realistic model. And the wax up, after the wax up, the try-in was done, and processing was carried out in the regular manner. Only thing which we did a little different here was that we impregnated some glass fibers in between acrylic to give better strength to the prosthesis. Then the surgical insertion was done at the OT by the neurosurgeons, and you can see the results. Now, coming on to the advantages of manual technique, of course, this is a prefabricated kind of a cranioplast which we give to the neurosurgeon, so it is better for them because there is no unnecessary exposure of the neural tissues which are vulnerable to the environment. And since we have molded it in beforehand, and also the try-in was done, so predictable contours are expected. Thermal protection of the neurological tissues are also gained out of this, and there is no interference in the EEG, and if it is an economical method of making the cranioplast. Then disadvantages are that inaccuracy in analog, since the impression is huge, and and then manipulation of the material and tissues becomes little difficult. So inaccuracies and analog can lead to inaccuracies in prosthesis also. Then only the defect is actually, we are concentrating on the impression making of the defect. So that is why only the sectional impressions are obtained. So there is no, you cannot actually see the symmetry when it comes to the right and left side symmetry. So it is only on the basis of try and which we actually do it on the patient that we can come to know how good is the aesthetics. Then in comatose patients, it's actually become really difficult for a prosthodontist to take everything there, the ICU, and work there. Then increase surgical time for adjustment, because again the impression which is made here is at tissue level. When we are going to reflect the tissues and put the cranioplast at the level of bone, it sometimes need a lot of adjustments there. So unnecessary exposure of neurological tissues are definitely going to be there. So no mock surgeries are possible here, because we are just making the impression of the defect. We cannot actually manipulate many things on the analog, so mock surgeries are also not possible. Then when we come on to the advantages of digital technique, which is hybrid technique, it gives us better fit and contour, because the realistic models actually are bone level models, and the interference of the soft tissues is gone here. Minimal adjustments are required during the OT time. Then sectional analogs are also possible in this case, although we had got the complete model so that we can evaluate the symmetry and contour of both sides. But if this defect is small, the sectional models or sectional analogs can also be made. Then mock surgeries are also possible. So if sometimes neurosurgery people, they will say, okay, remove this kind of margin, we are going to remove during the during intraoperatively, we can remove it, we can show it to them, and prior discussions can be there with the patient as well as with the neurosurgeons, and accordingly the results and the outcomes can be much better than the manual technique. Then the models can be kept for future references also. If we want to discuss something in future related to the defect particular site, that can also give us, the models can help us in referring those kind of defects. No extra clinical armamentarium is required, since this is hybrid technique. Almost all the basic things which are there in prostho department are utilized for making this kind of cranioplast. The disadvantages,
Sorry
of course,
for the interruption, doctor. Your
Yes?
time is up. Sorry for the
All right.
interruption. Your time is up.
Okay. Can I conclude, please?
Thank you.
So combining
sure.
precision. Okay, so combining precision with customized designing of the prosthesis is requisite in achieving satisfactory outcome. The customized designing of prosthesis through, manual molding or hand sculpting is an attempt to improve the outcome of the cranioplast, which we give it to our patients. Thank you so much. Thank you for your patient listening.
Thank you for the presentation.
Thank you.
Sir, ma'am, you have any question? Himanshu, sir?
Yeah, thank you, Dr. Simran.
Thank you.
You have done a nice case, wonderful case.
Thank you, sir.
What difference did you find? You have discussed everything, but still, I will like to ask: the conventional method and hybrid method. What are the basic difference? What did you find?
So basic difference, which actually, is of paramount importance to us as a prosthodontist. The cranioplast which we are going to give to the neurosurgeons, they are actually going to secure this cranioplast with the help of mini bone plates onto the skull bone. And what the impression which we are making in the conventional manner, like the manual molding, it's the tissue level impression. So there is always a mismatch at the level. It's not the hybrid impressions are actually bone level impressions, which gives us better fit. There are less chances of secondary infections, and because when we are adjusting the manual made cranioplasts, during that some kind of gaping can happen, and neurological, the CSF leak or some kind of secondary infections can happen in manual manual cranioplasts. So I've made many manual and of course many hybrid by now, and I've seen evident differences. And one thing which I would like to mention here is, once this is just an incident I want to share. So once there was a defect which was almost square in shape, sir. So we made the manual impression, and neurosurgeons by mistake I would say anteriorly they positioned the cranioplast in other direction because of the almost same geometry. So what happened? There was a gaping and there was a secondary infection, and they had to do the revision surgery of the whole defect. So that is kind of a trauma, and also the trauma to both neurosurgeon and the patient, of course. So that is a major difference, I would say, is there.
But that mistake can happen with hybrid also, because
So, no,
surgeon
sir,
can
that cannot
put
happen. I would like to add on to this, sir. So once we are going for the surgery, sir, the prosthodont is always a company in the OT when such cases are happening in our hospital, sir. So what we do is
yeah,
we
yeah,
take
yeah.
the yes, sir.
Actually, this should be the point of emphasis. कि when we are planning this kind of surgery, prosthodontist should be the part of the team since
Yes,
beginning.
yes, yes, sir.
Since
Yes,
the
sir.
beginning, how
So
much we want to remove,
yes, sir.
and most of the time, this is very unfortunate in the
Right,
other center.
right, sir.
Prosthodontists are being called at the last only.
Right,
I
sir.
always emphasize on this. The prosthodontist should be the board member, tumor
Right,
board member since the beginning.
right,
If
sir.
your hospital is doing that, that is good.
So we always send the prosthesis to the OT 3 days prior to it for proper disinfection and cleaning. But on that day, we take the model also along with us, the 3D realistic model, so that we can tell the neurosurgeon about the orientation. So that really helps. So it's a interdisciplinary approach, sir, and I feel that prosthodontists are always there on the apex of the pyramid. So we should be the major part of the team, sir.
No, my query will remain the same.
Yes.
Whether it is hybrid or it is a conventional. If a prosthodontist are there, then he or she can guide the placement.
So for
That is not going to make any
yes,
difference.
sir.
That because that mistake can be done only in the presence of,
Right.
in the absence of
Right, sir.
prosthodontist.
So the
Okay,
incident which
that
I
is not an added
yes,
time.
sir, the incident which I shared with you, sir, was actually in the initial days when prosthodontist was not the part of the team, sir. After this particular incident happened, only that incident we
But technique is not going to change
right,
anything.
sir.
If your presence of prosthodontist is going to
Definitely,
change the
sir.
problem.
Definitely.
Okay.
Thank you so much. Thank you
Thank
so
you.
much for your input, sir.
Thank you.
Dr. Nupur, if you're trying to speak, I think you're on mute. We cannot hear you.
Can you please unmute me?
Yes, yes.
Ma'am, you're audible.
Yeah, you can hear me? Okay, okay. Dr. Harsimran, are you still there or has she logged off?
I think she has logged off.
Okay.
We have Dr. Vishwas, Professor Vishwas, who's back now. So if any question is there, you can ask him.
Hello.
Yeah. Professor
audible?
Vishwas?
Am I audible, sir? And
Yes,
am I
you're
audible?
audible.
Dr. Vishwas, you're
Yeah,
audible.
ma'am. Actually, sir and ma'am, just the end part of the poster was left. That was basically the difference between the conventional and the 3D printed processes. What are the main difference? Now, what I feel is when we plan to make a new innovative processes, we first need to know what are the disadvantages of the processes which has already been in use. So what we noticed was, which everybody would have noted, is that the main problem with the first processes was the conventional processes was that it was first non-functional. Secondly, the weight of the processes. Thirdly, dislodgement, because it's a single unit which is attached to the part which is no more. So there were very much chances of dislodgement, whether we use screw and whether we use ball and socket joints over the the remaining finger, or we use ring attachments to join the processes to the remaining finger. But in this processes, what we felt was, first of all, the weight was markedly less. We did a survey of around we have given this kind of processes to close to now 15 to 16 individuals, because we have recently started giving it. So when we recalled them after a month's time, we try to judge them on certain parameters, like what on a scale of 1 to 10. First of all, aesthetics in comparison to the old processes and new processes, then function in a comparison to old and new, and most importantly the attachment part, because it was so comfortable to the patient because of the lightweight. And when the fingers fold, when one finger folds, that is the mechanism which allows folding of the 3D printed processes finger. So it was very comfortable to the patient, and the most important thing is it helped them in starting to do the basic works, like because in front of the in top of the artificial finger processes, we made certain attachments. We took out a part of the attachment which is used in compasses. In compasses, we have certain attachments in which you can put a pencil, or you can put a paintbrush, or you can put a pen and close it, and so that it can be used. So the same kind of attachment, we cut it into half and we attached it to the tip of the fingerprinted processes that could easily be used by the patient, because right hand could be used to insert either a paintbrush or a pen or a pencil to fold it. And even if because this thing we tried in conventional processes also, which was acrylic based, but we couldn't achieve it because a patient cannot use his fingers for writing or anything unless and until the finger folds. So for function, we had to do something in which we could, achieve this thing. Secondly, when we come to the cost factor, till now there were initially in outside and out of India, there are many such kind of processes available, but they are extremely costly. So if we want to go for economical alternatives, somewhere between 1200 to 2000 rupees for a patient who so for a patient who can afford that. Plus, we also give from our side, we try to give as much discounts as possible, because we need to little bit make awareness about these processes, and the patient also feels much comfortable rather than the thick, bulky acrylic finger which we used to give initially. So, I would request, welcome any questions or anything. Anybody, sir or ma'am needs. Yes, sir. Good afternoon, sir.
Good afternoon. You have done good job. And you are telling the weight is less. How weight can
Yes,
be
sir.
less with this kind of attachments?
Sir, because the finger printed processes, basically the ABS, that is acrylonitrile styrene, which is used, that compared to acrylic, the weight wise it is much lesser. Secondly, because this is not the whole attachment, there are three different attachments. If a part of the finger is left, then there are only two attachments which are joined with a knuckle. That knuckle, which is a hinge kind of a joint, that is also 3D printed. So that knuckle
I
part is totally
understand,
gone.
but
Yes, sir.
when we are adding two different parts and we are putting this movement, okay,
Yes, sir.
so we have to attach these ball socket joints.
Yes, sir.
So that will be give us extra weight, no?
No, sir. These joints which we are making, that is also 3D printed also. Only we are not using any. We are not using any metallic parts or anything. The whole processes.
Okay.
If we see figure number 3 and 4, that is why I put different parts separately. It is close to around 20 to 22 parts. If a full finger is made, if a full finger is made, it consists of 28 parts. So like we have, there are certain DIY toys which are available for children in which they
Okay.
in which.
Okay.
Yes,
I got it.
yes, sir.
And what about maintenance of the processes?
Sir, regarding the maintenance part, only the string which we are using, 3D printed parts, there is we have, when we have done survey of 6 months, there is hardly any attrition in the 3D printed components. Only thing is the string part which is there, that needs to get replaced after every 3 to 4 months, because that string is the key which is causing the movement of the finger straight and downwards. So that string parts, after 3 to 4 months, we have seen that it doesn't break off, but there is some wearing action on the string. So because the string is very close to the skin part, that is why we tend to change the string part after every 4 and a half months or so. We advise the patient to get it changed. Otherwise, he can use it for a longer time also.
Okay.
But the main difference which we saw, sir, was that we have our videos also, which I could not incorporate in the posters, in which we have made videos in which the patients are using the same processes for maybe painting something or maybe writing, which have definitely helped them in a certain kind of different
So
livelihood.
that we can appreciate. That we can appreciate.
Yes, sir.
Whatever you're saying, we appreciate it. I know that kind of movement is possible
Yes,
with this
sir.
kind of process.
Yes, sir.
Okay, good work done. Keep it up.
Thank you, sir. Thank you, sir. Sir, any other questions, ma'am? Anything, please? You're most
Dr.
welcome.
Vishwas,
Yes, sir. Yes, ma'am. Sorry.
is the band that you made over here, is it adjustable?
Yes, ma'am. That band is made according to the when the initial measurements of the finger are taken. that time the band is also measured, because it needs to go from the wrist to the point where it is inserting into the 3D printed finger. So that is
Okay.
adjustable, and it is as the patient is using it, because it is from one attachment to the other attachment, so there's hardly any loosening. We keep it little tight, only then the finger is going to start moving. So only thing what the band requires is maybe when if it becomes little loose after 4 to 5 months, you can just replace it. It's just a 2 minutes job, because we have made two round hooks, one at the in the center flange of the middle flange of the finger, and one on the wrist. So the like a rubber band, you just need to change it. It just takes a minute to change it. That too is
And what
if
about its wear and tear with respect to like sweat or environment? The
no,
band
ma'am.
and the band that you wore here.
Yeah, the band which we have given, the band we have covered it. If you see in the picture, we have covered the band also with a silicone sheet, so that sweat and everything, there is least minimum effect of sweat and everything on the band. So even if worst to worst, maybe in few months time, if the patient, as of now when we have taken 6 months follow up, we haven't seen anywhere in that silicone band, except that sometimes it gets dirty because the patient is wearing it continuously. So if that is the case, only thing which we need to use is we need to do is just change the silicone band. Otherwise, there is least possibility of getting the silicone band loosened, because it is made according to the size and there is no elasticity in that band.
Dr. Vishwas,
Yes,
I
ma'am.
had a question. You said you are using acrylonitrile styrene for this.
Yes, yes,
Are you
yes.
using FDM printer for the same and using the spools, or you're using the liquid resins for that?
No, ma'am. Liquid resins are basically, see, our purpose is that we need to have something which is little lighter in weight, which does not have that much density as compared to the resins which we use commonly in prosthodontics.
Okay. So
So, so
how are we getting it, and which company sells this?
ma'am, see, right now the software we have derived from outside. There's Mr. Walker Claus is a person who has designed the not the software specifically for fingers, okay, like the CNC software which we usually use commonly for prosthetic components. We have tried to incorporate that thing in our commonly available softwares which are available in India. So what they tell us is that the more and more we try to we this is something which I have just started. The more and more orders are increasing from different places in related to this, the cost would definitely try to come down more, so that the patients, more and more patients, can be beneficial, because these are the patients who sometimes go directly for an acrylic processes, because acrylic processes are sometimes given free of cost also in colleges.
So
So
these 3D printed ones are outsourced. These joints which you have written, they
no,
are
ma'am.
basically
No, ma'am. We have fabricated it
printed.
ourselves. Yeah,
You have printed it.
we have printed it here only in the labs in India only. Only
Okay.
the design part we have modified according to
The STL.
that is a design part which is customizable as per different patients. So it is not a single design which has to be used in all patients. It can be customized. So that is why in the first picture, if you see, we differently measure the middle part, the tip part, the back part, the thickness, and that on the
That's
on the computer we can change it according to the patient. So the fit is,
Yeah, that is
so from
customized.
where, which company have you procured the liquid resin, the styrene resin basically?
ma'am,
It is printed here.
right now we have taken help from Dentcare only. Like
Okay.
we have, like there are, I'm from Gurgaon. There are certain labs like LabDent also in Gurgaon. Now the
Okay.
difference is the cost which Dentcare and everybody quoted us. We are getting the even a lesser cost in 3D printed. Not only dental labs, there are many 3D printing companies in Gurgaon who are 3D printing not only dental stuff. They are like 3D printing
Then,
different types of like showpieces and everything and all those things. So
yes.
we have noticed that 3D printing, when we have contacted those companies which are 3D printing generalized stuff like showpieces and different things, there the cost factor is even lesser than our dental labs. So what I feel is, once
So
the
what
more
was
and
the
more the
cost of this entire prosthesis that you made?
ma'am, we have made it for many patients. It has ranged between 1200 to 2000.
Per patient.
Yeah, per patient, ma'am, per patient, depending from case to case. So what I feel is, but even in colleges, like when we started off in the
Per
colleges,
finger.
now I'm independently doing it also. What I've noticed is that those patients who are also were initially willing for a free processes, that is a hard, because we were not able to give them any other option only, because that was the only option which was like given to them, or we used to give them a silicon processes which was aesthetically little more pleasing than an acrylic processes. But when we shared the cost with them or so, and we also sometimes give them in like we 1200 to 200 is the cost, but I personally put some cost from my end also just to help the patient, so that around between 800 to 900 we can give the processes for them, because our main purpose is to help them out, like, and it's just a passion to help them out, that's it. Yeah, that's the main thing.
Dr. Vikas, is it possible that
Okay, we
instead
can.
of styrene, is the methacrylate only the liquid resins which are generally
Yes, yes, yes,
applied?
yes,
They are
yes. When we use acrylic methacrylate, the processes becomes more than twice the weight as compared to the regular one.
I meant the printed methacrylate, the printed resins, the printing
The
resin.
the printing resin से क्या होता है? Printed resins are not that the strength is not that much, because this needs movement. Apart from that, what can be used is graphene is another material which can be used, which is little more harder in density. So graphene is something which doesn't need to break it also. Yeah.
Thank you.
Okay, thank you.
Thank
Okay.
you.
Thank you, ma'am. And
Thank you.
sir and ma'am, sorry again. I'm traveling, so because that was the reason for the
Okay.
glitch. Like,
Okay. Okay.
so sorry. Okay. Thank you, ma'am. Thank you.
Thank you, Jesus. So our next presenter is Dr. Ria D. Kunha. So you can please go ahead with your presentation, doctor.
Good afternoon, everyone. Is my screen visible?
Yes, your screen is visible.
So the topic that I'm presenting today is digital impressions in dentistry. Digital imaging systems offer a wide range of benefits compared to the conventional technique. Introduction of intraoral scanners has radically changed the way in which the dentist approach restorative workflow. Precision, accuracy, and hassle-free procedures have made these systems user and patient-friendly. An accurate replica of the oral structures is required for diagnosis, treatment planning, and fabrication of restoration. Conventional technique has its own drawbacks in the form of material handling, patient acceptance, and accuracy. The advancement in computer technology and development of CAD/CAM has introduced digital impressions in dentistry. Digital imaging helps in making digital intraoral impressions, fabrication of master model, and to design and produce final restoration. Digital intraoral imaging represents an innovative method that enables the dentist to construct a virtual computer generated copy of the hard and soft tissues with the help of lasers and optical scanning machines. That brings us to the history of digital impressions. Dr. Duret in 1973 in France, in his thesis Empreinte optique, introduced CAD/CAM, which was further developed by Dr. Morman and Brandstein. Digital impression has a wide scope as it can be used in orthodontics for making splints and aligners, in cosmetic and aesthetic dentistry for smile designing and oral rehabilitation, in prosthodontics for crown, bridges, veneers, inlays, onlays, etc. It can also be used in oral surgery to scan inaccessible areas in case of limited mouth opening or trauma cases. It is used for mock surgeries and planning. That brings us to digital workflow. The first step is the acquisition of data. How does one acquire data? Either through intraoral scanners or extraoral scanners that scan the impressions or dissection models. If there is an in house milling machine, the dentist can fabricate the restoration on their own. Otherwise, the data is sent to the laboratory for manufacturing CAD/CAM restorations or customized restoration with the help of SLA models, that is 3D printing. There are different types of scanner systems which are available. It could be color or black and white. It could be corded or cordless. The scanning speed could be fast or slow. The different format in which the images are stored are STL, OBJ, and PLY. It could make use of single or multiple image acquisition, or it could be a open or close architecture. And open architecture means that the designing and manufacturing unit has to be of the same could be of different companies. However, in a closed architecture, you need the milling and manufacturing unit to be of the same company. It could make use of the powder or the powder-free variety. The powder used the titanium dioxide powder. It was a biocompatible material. However, the dentist looked for a hassle-free option. Hence, powder-free variety is more frequently used. The advantages are there is an increased accuracy of using digital impressions, there is increased efficiency, increased patient acceptance, increased lab communication. Also, same day dentistry can be practiced. I would like to conclude by saying that in future, growing technology will make the equipment more affordable. The impression wand will become smaller and user friendly. The rate of scanning and producing images will increase. The success. The primary requisites are purchase of the equipment and the initial learning curve, which can be difficult for some individuals. However, clinicians' acceptance and usage will make digital workflow a success. The future is digital dentistry. Thank you.
Thank you for the presentation, doctor. Over to you, judges. Is there any query or question? Sir, ma'am?
Sir, would you like to ask something?
Yeah, thank you, Ria. My first question: what are the limitations of digital impression?
So the very first difficulty would be the cost of the equipment. As we know, the equipment costs around 7 to 10 lakhs. Also, the learning curve, as we have been taught only basic like alginate impressions or the conventional techniques, it would be difficult to adjust and adapt to these techniques easily.
Dr. Ria, what is your view on digital bite registration? Do you think, how accurate do you think it is compared to conventional?
Don't know, ma'am. Sorry.
No problem. Let's move on to the next presenter.
Thank you.
Okay, ma'am. So our next presenter is Dr. Anki Chabrani. You can start with your presentation, doctor.
Yes, ma'am. Good afternoon to all the judges. I'm Dr. Ankita Chabrani from JSS Dental College and Hospital. I'm doing my PG in periodontology. The topic of my poster presentation is basal implants versus conventional implants. Rehabilitation today, substituting the missing teeth with implants, has become a predictable treatment option. However, adequate amount of bone is required for the successful implant placement. Due to the poor quality and quantity of the implant bed, these ended up to the discovery of basal implants. So now there are types of basal implants such as screw, disc, plate, and others. In the figure, I have mentioned the compression screw design, the bicortical screw design, the basal osseointegrated implant, the compression, and the bicortical screw design. Now compared to the basal versus conventional implants, basal implant kits, these surgery kits have a very few instruments. The mechanism of action, they have osseoadaptation instead of osseointegration as in conventional implants. Basal implants are indicated in wide range of patients. They can be immediately loaded within 72 hours. They are cost effective. There is no need of additional surgery such as bone graft, flap surgery, sinus lift procedures. They can be immediately loaded as in single visit surgery, and there is high patient satisfaction. Coming to the indications of basal implants, they are indicated in edentulous cysts when there is procedure of two implant placement that has failed in cases of severe bone deficiency. Contraindications: if the person does not have sound anatomical knowledge, if excess sound bone reduction has been done, and there is loss of good bone support. Overload osteolysis can be seen if load distribution is not done properly. Conclusion: basal implants outperform crestal implants in terms of reducing treatment duration and having a lower failure rate. The future perspective of basal implants are, in long run, they have not been determined. However, the entire concept is based on basal bone, which is more secure bone available for implants and results barely in any bone loss. Thank you.
Okay. Thank you for the presentation, doctor. Any queries, judges? Sir, Himanshu, Dr. Himanshu, sir?
Yeah, I could listen half of it. Can you tell me what are the advantages of basal implants in comparison to regular implant?
Part
Please carry on. Doctor, really you can ask the question.
Okay, Dr. Ankita, I have a question for you.
Yes, ma'am.
Do you think basal implants are controversial?
Yes, ma'am, because many research studies have not been done, but yet
Okay.
evidence-based studies have proven them to be little effective as compared to conventional. Because in
Okay.
smokers also, the failure rate of basal implants is 30%, and in alcoholic 3%. Also in periodontitis patients, we can give basal implants. So due to the wide range of patients in which we can give basal implants,
Okay. So if there's a staunch believer of conventional implants, say I'm a staunch believer of conventional implants, how
yes,
will you convince me कि नहीं basal implants are good and ma'am you must try it? How will you convince me?
ma'am, the patient wants treatment in one-time visit. Usually, the patients will be like they are impatient and they want in the first visit only the loading of the implant. So, basal implant can immediately load it.
Okay. And we can load conventional also with a temporary prosthesis.
Yes, ma'am, but then you will have to again recall the patient for permanent prosthesis. And basal implants, you can load it.
But basal implants, you won't recall him for adjustments or follow-ups.
Oh, yes, my follow-ups have to be done for everyone. But also, I feel oral hygiene maintenance in case of conventional implants is little difficult because the basal implant design is made such that the entry of the bacteria and the visit that point is distant to the base of the implant. So the failure rates could also be.
Dr.
Dr.
Ankita, yes, I have a question. What is your say of basal implant in single missing tooth?
Ma'am, in single we not immediately load. It is
Yes.
for denture, like complete dentures we can immediately load, but single visit it is better to wait for 6 months.
Yes, and not even 6 months. What is the another disadvantage of basal implants which you find? Like, what is the another disadvantage of a polished surface and an active surface? Because you have those threads which
Yes,
are very active. So, what is one strong disadvantage which you feel may not give you a very precise result as compared to conventional and osseous implant?
and due to the design, their mechanism of action is different, so the
Yes.
roughness is
What happens is it is an active implant. It is a polished surface. So what happens is because it is active, it has the capability of shifting and talking itself.
yes,
So there are times when you are or probably you have left the patient or the patient has bitten over it, or if you have a patient who has a soft bone. So sometimes what happens is because the threads are so active, by the time your prosthesis comes or it has a chance of changing and shifting its position. That is also one disadvantage of an active thread which you may have. Then, in osteoporosis cases, have you seen these basal, the conventional basal implants, how they look and how they are performed? You have to twist it.
yes,
You have to take it, hold it, that thing gets cold welded, and you have to twist it. So, what is your say if a patient is having osteoporosis?
osteoporosis cases, I would not prefer
It is
implants.
contraindicated.
No,
Say it.
No, not absolute contraindication, but it is better to not go implants in such cases?
No, but you can, a person who has a controllable osteoporosis, the cancellous bone is still into a molding stage, right? It is not, what happens is when you are correcting an osteoporosis and the medicines, they are modifying the cancellous bone, but they are not modifying the basal bone. So endosseous are still to some extent successful in those. And I was totally not agreeing with one of the statement that it has lower failure rates, because what happens is a lot of time what I have seen what people do is during the placement only they remove it, because they have not found enough anchorage. It is just going, and you just don't find an initial stability which is good enough, and then you remove it, but that data never goes into the study parameters. Or sometimes even what happens is, what I've seen people doing is they will place, and because as I said the threads are active, when they are trying to load it that particular time it is not fitting, so they will remove that. So that also, because within a span of 3 days they have removed, that also has not gone into the right criteria. So we do not know the data which we are getting is also a very
Biased.
valid data or not. Yes.
Yes, ma'am.
Yes, I'm glad you touched
Okay,
this
thank
topic.
Thank you. Thank you, ma'am.
you, Dr. Ankita.
Thank you,
Next,
sir.
we can go ahead for the next.
Yes, sir. So our next presenter is Dr. Vijay Lakshmi Mohite. So doctor, you can start with your presentation.
Good afternoon, respected judges. Today I'm going to present my poster titled as Applications of CRISPR Technology in Pediatric Dentistry. I would like to start my presentation with a quote by Bertrand Russell, a well-known mathematician and a philosopher, as science may set limits to knowledge but should not set limit to imagination. Such drive has led us to an era where alteration in human genome by human is possible. It was eugenics in 1883 by Francis Galton, who hypothesized that genetic engineering, who hypothesized that genetic knowledge can be directly applied for improvement of human existence. Genetic engineering is comprised of intentional manipulation of genes and recombination of genes. This genetic engineering and recombination of genes is done with the help of bacteriophages and bacteria. Bacteriophages are the viruses that infect bacteria, and to those infections, bacteria or prokaryotic cells have some adaptive immunity in their DNA structure naturally. In 1987,
Dr. Vijayalakshmi, sorry to interrupt.
yes, sir.
Your voice is
Like, can you talk little slow? You're going too fast.
Okay, sorry, sir.
Yeah.
and voice is not continuous also, some that issue.
Sorry, sir.
You can reduce the moments. You can reduce the moments so that it will get the voice clear.
Okay, sir.
You can continue.
Yes, sir. In an DNA sequence of prokaryotes, there is an unusual loci where there are some DNA fragments which are separated by short palindromic base pairs, and they are arranged into clusters. They were first identified in E. coli by Ishino in 1987, and their significance was put forward by Francisco Mojica in 1995, as these clusters are responsible to provide the adaptive immunity to those prokaryotic cells. Again, after that, in 2003, it was adopted that this adaptive immunity of these prokaryotic cells can be introduced or recombinant in human DNA, so that certain immunity or prevention of certain infectious and non-infectious diseases can occur. So these technology and the sequences were named as CRISPR. CRISPR is an acronym that stands for clustered regularly interspaced anadromic lipids. Their applications are there in agriculture, medicine, pharmacy, and they can be applied in dentistry as well. They're in field of medicine. It is under clinical trial to be used against certain infectious and non-infectious diseases like human papillomavirus, cancer immunotherapy, HIV. In Rosamondo et al. In 2021, there is one article where he hypothesized and focuses in field of dentistry where what other opportunities or what are the gaps within the dentistry field and what all treatment modalities that we all can opt and what are the future perspectives of the dentistry. So conventional dentistry is focused on treatment of certain bacteria diseases, mainly caries and periodontitis. But with the help of gene analysis, and we have multiple data available where we could now identify which genes are there and which genes are responsible for certain certain conditions like cleft lip, cleft palate. By understanding those gene and those loci, application of this CRISPR technology can be applied to prevent these genetic dysmorphogenic conditions in children as well. This CRISPR technology utilizes along with to cleave those sequences. Cas9 is an enzyme which is used to cleave those DNA and to basically make double DNA strand, single DNA strand, and the repair automatically generates as a mutation, and that probably prevents the infectious and genetically driven dysmorphogenic condition in dentistry. So this is the future prospect and emerging branch. And in the same article, Rosamondo hypothesized that the dentists that do this gene therapy and involved in gene counseling can be called as they can be called as biodentists. Thank you, sir.
Thank you for the presentation, Dr. Vijay Lakshmi. Any questions, sir? Ma'am?
No questions.
Thank you, sir. Any questions, ma'am?
No questions.
Doctor, unfortunately, understand most of technical glitch, I guess,
Yes, ma'am.
which is not. I just want to know the poster competition, the application of CRISPR technology in.
Sorry, ma'am.
Ma'am, your voice is not clear. No, ma'am. Ma'am, you're not audible.
It is audible, but there is a lag. Bit.
The application of CRISPR technology.
I think she's asking the application of CRISPR technology in the field of prosthodontics. Can you elaborate, please?
This technology is mainly used to prevent certain conditions. So in field of prosthodontics, the data is limited. So I cannot say.
Let's move on. Sir,
Yes.
sir has a question.
No. Thank you.
Okay, moving on to the next presenter, Dr. Vaishnavi Lolach. You can go ahead with your presentation now.
Yes. Good afternoon, everyone. My topic of presentation is 3D printed antimicrobial space maintainers. The occlusion in primary dentistry is utmost important as it plays an imperative role in stability and development of permanent dentition. Early loss of primary teeth can result in permanent teeth malocclusion, decreased arch length, difficulty in mastication and speech. Space maintainer help in maintaining the space created by premature loss of deciduous teeth. Space maintainers are
Can you
designed.
please
Designed.
the screen?
Hello. Hello, ma'am.
Can you please share your screen?
Ma'am, I don't have option of sharing screen here.
We can see her screen actually. Her poster is there in front of the screen.
The image is put up on the screen, doc. I think you can just refresh it once. There will be network glitch.
Okay.
You can continue, doctor.
Case study is that the goal of space maintenance is to preserve arch length, arch width, and perimeter by maintaining the relative position of current dentation. Designing a space maintainer not only includes the space analysis of space in a question but also the total arch length. The case which I am presenting was a 6-year girl reported to the Department of Periodontics and Preventive Dentistry in DYBDS Lohgaon. The chief complaint of the patient was decayed tooth in upper left back region of jaw since 3 months. On clinical examination, the oral hygiene of the child was fair. The grossly decayed 6-4 was noticed, and in periapical radiograph, 6-3, 6-4, and 6-5 was revealed with a gross coronal radiolucency associated with 6-4 involving enamel dentin and pulp. A study model of maxillary arch was done and space analysis was conducted. The space deficit was revealed that it was 0.8 mm. The conclusion of the analysis indicated that it requires the space maintainer. In 3D printed band and loop space maintainers was designed and fabricated using 2 components, band and modified loop using cobalt chromium. Unilateral arm was originated from middle third of the crown of 6-5 and proximal part was then designed to adapt along the palatal alveolar contour of missing 6-4. Was then continued below the mesial contact of 6-3 and adapted to the mesial contact. The appliance was made by first making digital impression. Digital impression was made for both upper and lower arches as you see in that poster. The appliance was finished and polished using grid finishing stone and buff. The application was of quaternary ammonium salt was done using Penton technology. Quaternary ammonium salt has antimicrobial effect and it is frequently used in many industries. Since the concept of immobilized antimicrobial effect, the dental restoration containing quaternary salt has been researched on, and it is also known to reduce the secondary caries. Many researchers has been of developing a novel anti-carious material which might have explanatory benefits such as antimicrobial effect, good mechanical properties, remineralization potential. Conclusion for my project was the space maintainers form an integral part of preventive and interceptive orthodontics. No 2 cases are similar. Choice and type of space maintainer must be governed by factors backed upon the literature and presenting the clinical scenario. Thank you, sir.
Thank you, Dr. Vaishnavi. Queries, sir? Ma'am?
Yeah, my question is 3D printing or you are focusing on antimicrobial property of the.
Sorry, sir, I am not able to hear you.
Yeah, my query is you have covered 2 things. One is the antimicrobial efficacy of 3D printing. So how they are?
So 3D printing Sir, 3D printing technology is used for fabrication of dental appliances. The appliance components are built up by layer. It is possible to design passages and internal features that could not be used as a cast or and complex assemblies of geometries with multiple parts are simplified using 3D printing.
So how to antimicrobial efficacy? Topic is
Sir, quaternary ammonium salts are applied by Penton technology on the 3D on the space maintainer which we have procured, and the inherent properties of quaternary ammonium salt will leads to antimicrobial efficacy.
okay. Thank you.
What is the longevity?
Hello, ma'am.
How long?
Hello.
How long do they last?
Ma'am, it will last till the paint is there on the space maintainer.
Okay.
It will gradually reduce by
Studies
saliva.
statement.
No, sir.
Okay. But
Hello, ma'am. Hello, sir.
what are you doing? You
Yes, sir. I am a final year student, sir.
okay? Nice.
Thank you, sir.
All the best for your exam.
Thank you, ma'am.
Good luck, Vaishnavi.
Okay.
It was a good attempt. Yes.
Thank you, ma'am.
Okay, now we are done with all the presentations. Thank you, judges, for taking out your precious time and making this event a very successful one. I also want to thank Dr. Roxanne Samuel, sir, editor in Dental Reach, Dr. Said Ahmed Rahil, sir, editor of Dental Reach, Dr. Nupu Sheerao, ma'am, editor in Dental Reach, and Dr. Zainab Kasid, ma'am, head media and PR at Dental Reach, without whom this program would have been impossible. And thanks to all the presenters, your results will be announced soon and you will be informed accordingly. Thank you so much.
Thank you.
Thank you, sir.